Okay, we are moving into our answering questions and wrap-up session. So during the lunch hour yesterday and today and in between, we've been busy answering questions. You got the answers to some of those questions yesterday. We'll answer as many more as we can today, and then either we'll run out of time. Louder? Is that better? Okay. So we will answer as many questions as possible today. There may be some that will require additional research. Those will be posted in a Q&A document that will ultimately go up on the Home Health Quality Reporting Program training webpage. But in the interim, I'm going to turn it over to my colleagues, Ann Spinard, Heidi McGladrey, and Ann Deitch, to answer as many, again, of the questions as we can at this time. So thank you.
Hi, everyone. Okay, we're going to start with my questions from the section M that I did. So the first question is, how should M1311 be answered at the SOC ROC if a patient refuses to have the dressing removed? For example, the caregiver states, I just cleaned the wound before you got here, please leave it. Because the skin assessment was not conducted on the first visit, the original assessing clinician may collaborate with a second nurse who is completing the first clinical skin assessment regarding the presence/status of any pressure ulcer, as long as the assessment is completed within 5 days of the SOC date. Providers are encouraged to complete the assessment as close to the start of care, resumption of care as possible. Let me just go down here. So the second question is, what if the agency declines or does not perform the initial skin assessment until day 3, when the dressing can be removed? Assuming you were referring to a non-removable dressing that the first nurse is visualizing, the pressure ulcer should be reported as unstageable due to a non-removable dressing or device, as that would be the status at the first skin assessment. This is true even if a second nurse observes the wound as a stageable pressure ulcer at a visit occurring within the 5-day assessment time frame. So our next question is, in the start of care, a non-removable dressing, 4 days later the dressing is off, now seen as a stage 4. Is the home health agency seen as responsible for the stage 4? In this situation, the OASIS would be coded on the start of care as unstageable due to a non-removable dressing. In this case, once the dressing is removed and staged as a 4, the wound would be considered present on admission for the discharge assessment if it is still a stage 4 and, for example, wasn't covered with SLEF or eschar. So in that sense, the agency wouldn't be tagged with having that ulcer. Okay, so next question here. Doctors are notorious in not providing wound ulcer classification. As an RN, can we discuss it with them and recommend the classification? And if they agree, is it acceptable that we document in the clinical record that the MD had verbally stated the classification? So our response is, a pressure ulcer/injury may be reported on OASIS based on visualization of the wound, patient assessment, and interview, review of relevant related historical documentation, and clinical judgment, re the etiology. Although the assessing clinician can report the observed ulcer/injury on the OASIS integumentary status item without physician confirmation, collaboration with the physician is required in order to add a diagnosis and ICD-10-CM code on the OASIS diagnosis items and the patient's plan of care, and to receive related orders and/or provide physician-ordered care related to the pressure ulcer or injury. So the next question actually just came in is, what about a skin graft? And I'm assuming they were talking about what about a skin graft related to the pressure ulcer. So a pressure ulcer that has had a skin graft would then become a surgical wound. So remember, the two things was a flap and a skin graft. Once you have those related to that pressure ulcer, they then become a surgical wound and not a pressure ulcer. Is a Clagett window considered a surgical wound? Well, first off, I had to look up a Clagett window because I wasn't familiar with it. But really, we kept this related to this item. This type of procedure would not be coded in M1311. The next question is, on scenario 2, it has with referral documentation indicating the presence of a stage 3. I understood you to say you could count the stage 3 if it was documented or verbal handoff. So why would you not document a stage 3 present on admission? So I think what's missing from this question is they probably had a non-removable dressing. So you know that you have a stage 3. It's been reported to you under a dressing or a device that you can't remove. In scenario 2, the known pressure ulcer injury is covered with a non-removable dressing so that on the SOC-ROC assessment would be coded as unstageable, non-removable dressing or device. In this case, once the dressing is removed and staged as a stage 3, the wound would be considered present on admission for the discharge assessment if it is still a stage 3 and hasn't declined. Next question, if a home health agency policy allows for 5 days to finish the OASIS, then wouldn't the dressing found as stage 3 on scenario 2 be considered a stage 3 pressure ulcer? And so again, you see where people are struggling because you have this 5-day period of time. And so here, per CMS directions, M1311 would be coded as unstageable, non-removable dressing or device, as you must code on what you found on the first skin assessment or that initial skin assessment. And these are probably the most common questions that we have gotten over the multiple times that we've done this. So this is an education point of view. If you know you have an ulcer, so it's an identified ulcer under a non-removable dressing or device, then you code it as that on the start of care. And then as soon as you can remove that device or that dressing and you first stage it, it then becomes present upon admission. Okay. Next question, skin integrity scenario 6. If the patient had 2 stage 2s on the elbow on admission, but they advanced to 2 stage 3s, by discharge, these 2 stage 3 pressure ulcers became 1 large stage 3. At discharge, how many stage 3 pressure ulcers would be coded? It's actually not an uncommon thing that happens, and we call that actually a skin bridge between 2 ulcers. In this scenario, if you can no longer differentiate one pressure ulcer from the other, meaning they were so close together and now they become one, this is considered 1 pressure ulcer at discharge. So there's no definitive borders to show it as 2 that for measurements, 2 areas, then that would be considered 1, in this scenario, 1 stage 3 at discharge. The question is, although this isn't noted on the OASIS item, please help me understand when a patient would be discharged with an unstageable wound. Would an agency be required to continue to see a patient until their wounds were healed? And our response is, there could be reasons that an agency would discharge a patient from service. Examples include discharge to hospice, discharge to another home care agency, relocation, etc. So those are some of the reasons that you might discharge someone. Another question is, what if a patient allowed a partial skin assessment day 1? For example, they didn't allow us to look at their buttocks, but then let us complete day 4 and a pressure ulcer was found. How would this be scored? Would we be able to capture the pressure ulcer? Because the skin assessment was not conducted on the first visit, the original assessing clinician may collaborate with the second nurse who is completing the first clinical skin assessment regarding the presence or status of a pressure ulcer, as long as the assessment is completed within the 5 days of the start of care date. Providers are encouraged to complete the assessment as close to the start of care or resumption of care as possible. Just a couple more questions for me. So if a DASH is considered as usable response for pressure ulcer measure M1311, or does a DASH result in a denominator exclusion? So first off, the DASH is allowed in the discharge for M1311. So I just want to clarify that point first. A DASH is not a usable response. A quality episode would be excluded from the denominator when a DASH is the response for M1311 A1, B1, C1, D1, or E1, and or F1 at discharge. So it would be excluded. In slide 14 lists GG0170C, M1028, M1060, and M1620 as proposed risk factors. The January 2019 revised risk adjustment calculation tables do not include GG0170C, M1028, or M1060. Are these questions not going to be used for risk adjustment? If not, will M1028 and M1060 be removed from the OASIS? And the answer is, based upon the ongoing data analysis, CMS is planning on using these items to risk adjust the quality measures of change in skin integrity post-acute care, pressure ulcer, or injury. So I'm going to turn it over to Heidi. You can just click down here.
Okay. So some questions about Section J, health conditions. We had a question, did you think about the cost of scales for each patient? CMS recognizes that quality improvement efforts may require resources. And while an agency may choose to purchase scales for their patients or for use by visiting staff, staff may follow agency policies and procedures, including utilizing patient scales. If a patient cannot be weighed, a dash can be reported on M1060B weight. If the measure is only when the patient had a major injury, could we simplify by having one question? Did the patient have a fall with a major injury, yes or no? J1800 and J1900 items are standardized across the post-acute care setting assessment instruments. J1800 is a gateway item for J1900, while J1900C is used to calculate the falls with major injury measure. The CASPER Agency Patient Reported Characteristics Case Mix Report and its corresponding tally report provide agencies with information on their J1800 and J1900 rates that can be used to inform agency quality improvement measures. Okay. Meaningful quality reporting is the goal. How can CMS hold agencies accountable for data when patient is non-compliant? Example, patient did not take the recommendations given by clinician to change home settings. Now the agency has to account for a fall. How is that meaningful for the agency? CMS recognizes the uniqueness of the home setting, including patients' capacity to directly and independently manage their environment and healthcare needs. All of the measures adopted for the Home Health Quality Reporting Program were tested for reliability and/or validity, and CMS believes that the results of that testing support the conclusion that the measures are sufficiently reliable and valid. While we acknowledge that various patient characteristics can elevate the risk for falls, falls with major injury are considered to be never events, and the varying risk factors among patients does not remove the obligation of providers to minimize the risk. Why isn't a major injury caused by an external force not counted in the falls quality measure? This quality measure is standardized across PAC settings and contains items that are collected uniformly in each setting's assessment instruments. The definition of a fall is standardized across the 4 post-acute care settings and specifies that falls are not a result of an overwhelming external force, such as a person pushing the patient. And our last question, I've never used our OASIS Educational Coordinator. What do people typically use them for? And each state has designated an OASIS Educational Coordinator with the responsibility to ensure that all home health providers in the state have access to training in the OASIS Dataset Administration for assessing patients and training and technical support in integrating the OASIS items in the agency's record-keeping system. And with that, I'll turn it over to Anne.
Great. Thank you, Heidi. Okay, so the first question was related to section GG. Where is the decision tree video located? The decision tree document is currently available on the Home Health QRP training webpage. The section GG presentation from today's training, including live links to the video recordings, will be posted on the CMS YouTube site. We are also hoping to post standalone versions of the videos, including today's section GG presentation, along with the video-based web-based trainings on section GG shortly. As those resources are posted, we will send anyone who has registered for today's home health training an email when the items are posted. The next question relates to a January 2019 Q&A guidance document for GG0170N and GG0170O, which indicates scooting up and down stairs or via any other safe method, non-traditional manner, with a portable device is captured. Does this guidance also apply to GG0100C stairs in the same manner? So they were basically asking about the prior functioning item there. When coding GG0100C prior functioning for stairs, if a patient goes up and down stairs by scooting on buttocks, code the patient's performance based on the amount of help needed to safely complete the activity. The next question, please review again GG0110. If the patient only used a cane and no other device, are we to check walker? Correct. Wanted to see again the rationale. So the answer is no. If the patient used a cane or a device that's not listed, you would just check none of the above. I think if you were referencing the video, the person used a walker and a cane. Because cane is not on there, the only one that was checked was walker. So I hope that addresses that question. Next question. Actually, there were several questions about the activity not attempted code, so this is just a sample example of a question. Examples of non-activity codes: lives in a home and does not have 150 feet to walk, or no stairs needed, required, or usual ability does not require patient to get into care, wheelchair bound, and does not ambulate, etc. So we just wanted to clarify that when completing GG0130 or GG0170, combine general observation, interview of patient and caregivers, collaboration with other agency staff, and other relevant strategies to complete any and all GG items as needed. If the activity cannot be completed and a performance code cannot be determined based on these assessment strategies, select an appropriate activity not attempted code. The next question, would a lift chair be considered a mechanical lift for GG0110? So again, we're back in prior functioning. For GG0110C, prior device use, a mechanical lift is defined as a device that the patient or caregiver requires for lifting or supporting the patient's body weight. Examples provided included a chair lift, Hoyer lift, or bathtub lift. Clinical judgment may be used to determine whether other devices, such as the electric lift chair described, meet the definition provided. Next question, if a patient sleeps in a recliner, how would you code the GG items such as rolling left to right and sit to lying? If the patient uses a recliner, sofa, or mattress on the floor as the patient's bed, preferred or necessary sleeping surface, assess the patient's need for assistance using that sleeping surface when determining ability for the item GG0110C, lying to sitting on side of bed. Next question, why is setup still an option with regards to eating, even though eating is no longer involving meal prep or serving? So I just wanted to clarify, because somebody actually did ask me about this also just at the table not too long ago. So eating would include assistance with opening containers. So if somebody is getting setup assistance, that would include somebody opening the helper opening containers or cartons for the patient, cutting up food such as meat once the family member or other person has placed the food in front of the patient. If the cutting up meat or opening containers happens before it's placed in the patient, that's still considered setup. And then the last question that we have for today, will the GG quality measure be included in the home health compare report starting in 2020? So the GG process measure, which I discussed during the presentation earlier today, will be available, those data will be available on the review and correct reports starting in April 2019. The Castor QM reports are expected to be available in early 2020, and the plan is for the home health compare to have that data in early 2021. So I hope that answers at least some of your questions, and I think we're passing back to Bridget at this point.
Can everybody hear me? We might, there we go. Okay, so first of all, I wanted to thank everyone for coming. Your time is valuable, and we really appreciate your taking time out of your days and week to spend time with us, and hopefully you felt it was a valuable use of your time. So thank you for it very much. In the way of a wrap-up, I just want to remind everyone that all materials with answers to the knowledge checks and pollings, the practice scenarios, and the various activities that you participated over in these last 2 days will be posted to the Home Health Quality Reporting Training Program webpage, and we will send you an email once they're posted so that you don't have to keep checking back. Additionally, video recordings of these presentations will be posted to the CMS YouTube site. We will alert you as well when that occurs. And similarly, we will alert you when the full Q&A document is posted to the Home Health Quality Reporting Program Training webpage. That will probably come out in stages, so you may get multiple emails, but we'll let you know as soon as everything is available, or as soon as each thing is available. Again, we do not offer CEUs, but for those of you who attended in person, you will get a certificate of completion, and you can submit that along with your agenda to a professional organization, and often they will give you CEUs for attending the training. Last thing that I wanted to mention is we have a end of session or end of course evaluation posted on Slido. Again, we very much appreciate receiving your feedback, and it helps us look as to how to improve these events, if there are other opportunities or things that you would like to see us do in the way of training. That is very helpful information to us. And we already, as I mentioned earlier, received a lot of feedback that you liked the videos and wanted to see those available for your use. So again, those are coming, and we will notify you when they are available. And we also coming is web-based training for Section GG that people can take at their own time. As long as you have access to the internet and a browser, you can take it 24/7 whenever you would like to, or ask others to take it. So with that, I think that brings us to the end of our session. The evaluation will be open until midnight tonight. So again, please do complete the evaluation on Slido, whether you're here in the room or joining remotely. And thank you very much again for your time and attention. Have safe travels home.